Injuries suck. I had a rather scary one recently. Late April, we were at Jiminy Peak, a small ski resort in Massachusetts. It was around 50 degrees, partly cloudy. Perfect day to hit the slopes, right? But in what is apparently referred to as the idiot run among experts, I seriously ate it on my last run of the day. With a rental ski on my left knee that did not want to eject upon collision, and ski poles in my hand that really hit it hard when I fell to the ground, I hurt myself pretty bad on that fall. And so began my journey into the depths of the American healthcare system. Dr. One was super friendly. He had 20 years of experience in orthopedics, and he did a full exam of my body, and he gave me just about the worst news you can give an athlete about their knee. I mean, seriously, ask Tiger Woods, Tom Brady, or Derrick Rose. All of them will tell you that a torn ACL is the worst diagnosis you want to get for your knee. But he said he wanted to order an MRI to confirm his diagnosis. I said, okay. So I got the MRI, and it came back negative. And so the doctor gave me a splint for my wrist and my knee, and off he sent me to my home. Having lost confidence in doctor number one, I went over there, and I got another consultation from doctor number two. Doctor number two said, hello, welcome. Do you have your CD of your MRI? I said, yeah, so I gave it to him. And what doctor number two said is, I'm going to go look at it in the computer, and I'll be right back. And so he left me in this oversized exam room, as most physicians do. And when he came back, he said the following in a stern voice. He said, there's nothing wrong with your knee. I don't know what Dr. One was thinking, but he's practicing old school medicine. We need to get you moving. And so he showed me hundreds of leg lift exercises and said, you know, medicine has changed. We need to get you moving. And so rather confused, I didn't know what to do. And so I did what I thought was best. I got a third opinion. What doctor number three told me really blew my mind. Dr. Three did his exam, and he said the following. He said, I don't know what doctor number one told you. I don't know what doctor number two told you, but you have a lot of inflammation, and you need to take a week of steroids. Otherwise, your injury's never going to get better. Three radically different treatment plans for one seemingly common injury. My ski injury is a perfect example of a constant struggle that our healthcare system faces today. The struggle between evidence-based medicine and anecdotal medicine. And that term, evidence-based medicine, really confused me at first, right? Like, I'm doing a healthcare MBA, and the first time they said that term, I thought to myself, what other kind of medicine could there be? But such is the case. And as you'll see, and as I go through these slides, here's the ski resort, and here's the study I want to talk about, you'll see that this failure to practice evidence-based medicine actually accounts for a lot of the research that has been done. And so I want to talk to you about a study done in the 1970s, here in the state of Vermont, land of Ben and Jerry's. What Dr. John Wenberg, one of the leading healthcare policy experts, wanted to study in the 1970s was something very simple. He wanted to compare different regions of the state of Vermont and see how medical care was varied, if at all. And what he found was shocking. It shocked the whole community. What they found is that there was severe variation, unexpected variation in different regions of the state in almost all aspects of healthcare delivery. And seated here, you might be thinking to yourselves, why is this guy citing a study from the 70s? But look, just in 2014, he published an article titled 40 Years of Unwarranted Clinical Variation, and still counting. And so a lot of the explanation for the clinical variation that Dr. John Wenberg found was explained by differences in the attitudes and beliefs that physicians had on various interventions. They just disagreed fundamentally on whether certain procedures were effective for certain diagnoses. The failure to practice evidence-based medicine is a major driver of the exorbitant amount of money that our health system spends on healthcare. I mean, seriously, compares to any developed country on the planet, any from the OECD, and we spend more money per capita on healthcare. But of course, that is not the only driver of our healthcare costs. In fact, it's not even the biggest one. But another driver of our healthcare costs in the United States is our love for imaging. Let's go back to Dr. One's office to talk more about this. So when the medical technician sat me down in Dr. One's office, she said, we're going to need an x-ray of your wrist and your knee. And I'm a curious guy, so I said back to her, how could you already know that I need an x-ray? I haven't even seen the doctor yet. She was honest, so she told me. She said, it's protocol. We do it for all our patients. Dr. Gilbert Welch talks about this in his book, Overdiagnosed. He admits that the advancements we have made in medical technology and imaging have drastically enhanced our ability to see inside of the human body, which is great, but it comes at a cost. For those folks who we find an abnormality in, they have to pay the price. Because when we scan more, we find more. And when we find more, we do more. And so for those folks who have an abnormality that would have never actually resulted in symptoms, acting on that abnormality is actually harmful to the patient. But hey, if we do so many tests, we must at least pay a cheap price for them, right? Wrong. And to give an example, let's talk about the MRI that I received of my knee. I went home to get it after we were in Massachusetts. The following day I had a flight home, and so I got the MRI done in California at a standalone clinic. My insurance company paid around $700 for the MRI to the standalone clinic. And at a hospital, it would have cost around double. But I couldn't tell you exactly how much it cost. Why? Because costs vary significantly depending on which part of the country you're in. Over here in California, on average, it costs $1,428 more to get an MRI in a hospital as opposed to a standalone clinic. But hey, let's go somewhere colder. Let's go to Alaska. In Alaska, it costs $3,200 more to get an MRI at a hospital as opposed to a standalone clinic, on average. Want to really have your mind blown? Let's go down the river to Mississippi. In Mississippi, it costs $97 more to get an MRI at a hospital as opposed to a standalone clinic. And you know what the reality was? The reality was that I honestly didn't really care where I got my MRI. Why? Because I had health insurance, and they were going to pay for it regardless. But what if I didn't? What if I, like 14% of the country, had no access to health care? One of two things would have probably happened. A, I would have waited for my pain to hopefully subside and never seen a physician. And at that point, I would have, not gone to the doctor at all. But what if that didn't happen? What if my ailment got worse and I showed up to the emergency department with a worse injury on Medicaid? That would have cost the health system a lot more money. Or the alternative, I could have seen my orthopedist and not been sure of whether I should order an MRI or not because I was going to have to pay for it out of pocket. Which, by the way, if you pay for out of pocket, costs around half of what an insurer pays for it. There is no magic prescription for our healthcare system. There just isn't. But there are solutions that we can look at, both within our system and in other countries, that offer frameworks for solutions. Dr. Edwards Deming, a quality expert, often hailed as one of the quality experts in the world, says that often the best way to reduce costs is to improve quality. And so let's go to Utah and Idaho and see how they do it. This is Intermountain Healthcare. It serves around half of all of the population in Utah and Idaho. It's around 23 hospitals and 160 medical clinics. And they have been consistently recognized as a low-cost, high-quality healthcare system. And they do many things, but one of the things they do is they collect and analyze data on clinical variation. And they do two things with that data. One is they feed it back to the providers and clinical leadership. And they say, hey, look at this. You guys are performing differently. The second thing they do with this data is more actionable. They take the data and they make process improvement initiatives. And since the 1990s, they've done over 100 of these initiatives. And of course, I don't have time to talk about all of them, but I do want to talk about one. And it has to do with early child induction, because, hey, babies are cute, like this one. So Intermountain Healthcare decided that, hey, we do over 32,000 deliveries a year. And so early child induction means trying to induce labor early, right, for the expecting mother. And so they came out with a protocol, an algorithm. And so their process is really simple. They gave nurses an electronic check sheet. And if the expecting mother meets the criteria, they go forward with early child induction. If the mother does not meet the criteria, well, then they just don't go forward with early child induction. It's simple, right? But it saved the state of Utah alone $50 million a year. And estimates are that if the United States were to implement this on a nationwide basis, we would save around $3.5 billion. But hey, that's only a scratch on the $3.5 trillion, with a T, dollars that our healthcare system spends per year. But hey, enough of discussion inside the country. Let's go abroad, shall we? A couple summers ago, I went with Dr. Terry Weiner, a health systems expert, to 3 developed countries to study their healthcare systems: Britain, Canada, and the Netherlands. And today I want to focus on the United Kingdom, whose health system is famously known as the National Health Service, or the NHS. The NHS consistently outperforms our country on every single health outcome. They have high quality care, and guess what? At a fraction of the cost. And so the question is, how did they do this, right? Well, there's many answers, and again, I can't go through all of them, but one that I do want to go through is an organization they have called the National Institute for Clinical Excellence, or NICE. NICE is an organizational body whose job is to literally establish clinical guidelines for the procedures that physicians should be doing. And so they do this on 2 bases: cost effectiveness and clinical effectiveness. In other words, if there isn't a randomized trial to back up an intervention, well, they just don't do it. Enzalutamide for hormone-relapsed non-metastatic prostate cancer. And so they put out to physicians, hey, this drug is not effective. Don't do it. Don't use it. The trillion-dollar question in healthcare is not whether we can do better. The question is when we will do better. And I hope the answer is soon. Wish me luck at physical therapy later today. Thank you.